our collaborators, who include Hawaii Emergency Management Agency, Healthcare Association of Hawaii, Hawaii Association Directors of Nursing, Hawaii Medical Directors Association, and Mountain Pacific Quality Health. We usually have a brief presentation, and then we open it up for a time of questions and discussion up to 3 p.m. We ask you to use the chat box to submit and queue up your questions, which will be facilitated. Next slide, we have a schedule of upcoming sessions. Our next one is the 15th, July 15th, and actually it's going to be interesting. COVID facilities and cohorting, and actually I think our plan there is to talk about surge planning, COVID units, COVID facilities, updates regarding nursing homes and absorbing care home patients and hotels for heroes, all kinds of things, maybe sustainable testing strategies. So it's going to be a very interesting one. It's going to be basically much more Q&A than didactics, and we'll be able to pick the brains of some of our HIEMA leads. And then the next one that's really interesting actually is August 19th. The date is wrong over there, and it's hospice care in the time of COVID. And we're inviting a geriatrician and palliative care physician in New York City who basically has a lot of great insights on strategies for symptom management in the COVID era and how to do that PPE, screening, home care, and all that sort of stuff. So lots of good sessions coming up. So make sure to join us. Next slide. We will be offering CMEs and CEs and offer certificates of attendance for those who complete an evaluation form. And if you haven't registered, right after this webinar, you can click onto that evaluation link, and you can still, the registration link, and you can still register and evaluate and get your CEs. So right now we ask you to enter your name into the chat box for attendance purposes. And if you are calling from a phone, we ask you to, I guess if you have a smartphone, then you can type in your name in there as well so that we can keep attendance correctly. Thanks. I see all the names coming up. I really like that. Okay, so today we have Trish Medeiros, and she is going to be speaking to us about relaxing visitor restrictions from assisted living facilities. So she's the Chief Operating Officer at Plaza Assisted Living, I guess multiple plazas. And we also have a couple of invited guests back from our May 27th session. We have Dr. Dan Hamowitz, wave hello. Okay, and he's a geriatrician practicing assisted living facilities in Pennsylvania. And we have Josh Allen from Allen's Consulting Group, and he is also on the mainland, also able to share experiences from there as well. So you can wave Allen, Josh. Okay, and then I'm just gonna hand it over to Trish. Go for it. Thank you so much.
Thanks for having me. We'll just go to the next slide, which is me. We can save this introduction, but I've been working in assisted living for over 25 years in the mainland and in the last 15 years in Hawaii, and I'm currently the Chief Operating Officer for the Plaza Communities, all assisted living. We can go to the next slide. That's not that exciting. Okay, so ultimately, our goal at the Plaza was to keep COVID out. That just everything we did was about keeping the virus out. And knock on wood, up until today, we have been successful. And now as we start relaxing our restrictions, we are assuming that everyone has COVID-19 that is coming into our building. And what you're doing is preventing it from spreading. And so the actions that we took were, okay, so there is going to be a staff person that's going to catch COVID. There is going to be a visitor that might pass the screening. And what we don't want to happen is it to spread like wildfire across all of our residents. And so we could go to the next screen. So one of the most important things is the screening. And we included our screening checklist. We created a trainer, and all of our screeners go through a training in order to screen people. We require them, obviously, to sanitize and to take a temperature, ask the questions about travel and exposure. And and we have a methodology of elevating these individuals that we're screening, and everybody gets screened. And it was funny, recently I went to visit the facilities to do a little audit, and the screeners were like, do we screen Trisha? No, you screen everybody that comes in, no matter who they are. So, and we have a sticker system to identify those people that have been screened. But my advice to you is everybody should be keeping these logs and keeping this information for liability reasons. You may need them. And the advice from the insurance company is to keep them for the next 4 years. Now, an alternate to screening is these automated kiosks that a couple of the assisted living providers have introduced in their communities. And they do an automatic temperature reading and you answer a series of questions. For the plazas, the staff just didn't feel comfortable to give up that face-to-face interaction. Now, I think screening is going to end up happening for a long period of time, even beyond COVID with reality. So I think in our future, we will have some kind of automated system. But with this being so new, all of our properties are insisting on doing a face-to-face screening. And it is easier to lie on your questionnaire than to a person that's at the door. So screening is very important, and I'm sure everyone is doing it at this point. Next slide. And then, okay, so now we're talking about resident egress and ingress. So next slide. The residents, half of them could care less about what's happening and happily content staying inside. And the other half are anxiously, wanting to run out the door. And the moment we told them that the stay-at-home orders are in place, they, clinched up and said, I need to go out for all these different reasons. So we've only been allowing residents to go out for essential reasons, and the administrator has to review what those essential reasons are. And our stay-at-home orders for Hawaii, the state expired yesterday. And so there's a sense that the residents are free to go. And our fear is if we didn't introduce visitations and we didn't introduce other steps, that they would want to leave the building. And so we've asked them to stay into the building for another 14 days, just to see what the numbers are and how things progress as the stay-at-home orders are relieved. And after July 15th, we will not mandate a 14 quarantine for residents. So currently, residents have a required 14 days quarantine in the plaza with our staff using full PPE if they leave the community or if they travel or all those type of things. So I think this is the most risky thing that we're doing, is allowing the residents out. And I feel pretty confident that most of them won't leave, but some will be. And they will be screened when they return. And they are asked to wear a mask for the entire time that they are outside of the community. And in the return screening, we've added some questions about participation in family activities with more than 10 people. We are asking that if those people that you were with continue to wear a mask, and those type of questions. So this is probably our trickiest next step in the relaxing. The next slide is an error. You can skip to the next slide, is visitations, and this is probably what the most important. So obviously pre-relaxing, we were doing a lot of window visits, we were doing drive-by visits, we had parades, the daycares and the nursery schools neighboring our communities were doing parades around the communities. So this alleviated some of the isolation, and we can go to the next stage. But the most important steps are on the next slide. As of today, we are allowing visitors. It's one visitor, it's by appointment, there's a 30-minute max, it's outdoors, and they have to maintain social distancing during the visit. Visitors are not allowed to cut through or walk through the community or access any of the common area space, so they're screened at the door. They have to wear a mask. There's no food or eating during the visit, no touching or kissing. We're teaching like elbow bumps and air hugs. No visitors under the age of 14. And prior to this visitation, we have been conducting Zoom education with all of our families and potential residents. And they receive a handout when they are screened about what the rules during the visitation would be. And they're forced to sanitize their hands before the visit. And so another alternative, if we didn't have the open air space, or let's say it rained for a long period of time, an alternate option would be to hold it in a large indoor area with high ceilings and good airflow, and still all the same rules about masks and social distance. So this is the next 14 days or 15 days we are introducing the visitations. And then our next step, which we anticipate happening on July 15th, as long as numbers still remain controlled, is to allow groups of 3 visitors. And we removed the age restriction, and we are allowing pets to visit also as one of the 3 people. So this was to allow for grandchildren. This was allowed for pets to come in and relieve some of that isolation for the residents. As far as the visitors that are underaged, we don't have an age requirement, but they do have to wear a mask. And an alternate to the face mask, if somebody medically can't, is face shields. And we have that equipment and available for our visitors when that happens. Okay. So then next slide was about communal dining, which we can go to the next slide. So a lot of ALFs had restricted communal dining and have been dining in their apartments. We are now allowing communal dining with social distancing. So previously, all meals were served on disposables. The meals had to be served by a nursing aide because that was the same person that was being exposed to the resident. No beverage, self-serve beverage stations, no self-serve food stations, no buffets, no sharing of food, no guest dining. Then we moved to a modified communal dining. So residents would come down, they would be assigned to a table by themselves, or a large enough table where you could achieve a 6-foot distance for social distancing. The servers had surgical masks and gloves. The same servers served the same set of residents. There were multiple seatings, no condiments on the table, sanitized hands at the table before dining. Residents had to wear their masks until they started eating. Spouse and roommates were allowed to dine together, and because we considered them as close contacts anyway in their apartments, so we didn't need to separate them during meals. And so this was where we're at now. There was a lot of talk about, well, why don't we just move to a 50%, allow 2 people to a table, but with the idea that if COVID comes into the building, obviously there's an exposure. So everything we have to do still abides by that social distancing rule. So the next slide is group activities, and we can move right into the next slide. Obviously, in the beginning, there was no group activities. We had individual kits, hallway activities, Zoom entertainment, and we have now released to allowing group activities with less than 10 participants, and that they have to be social distanced. Whenever possible, the activities are held outside for good airflow, and all the residents have to sanitize before and after. And this has made and we cut all of our activities and duplicated them. So if we had an exercise class, we do 2 exercise classes a day, and now we do 4 exercise classes a day. So just, they might be shorter in nature, but we allow for more opportunities for more people to participate. And for the most part, obviously no entertainers and no singers and those type of things. So I think that this has allowed for some socialization and interaction and has been good for our residents. Tricky thing, now we're getting on the next slide, tours. So trying to bring business back to your community. As I would imagine, tours and admissions have been greatly impacted at all the communities. As of 7/1, and we mimicked when visitations were allowed, that we would start allowing in-person tours. So we've been doing tours and Zoom tours for all of our properties, but on 7/1, we are going to allow face-to-face tours. We're limiting it to 2 visitors. Salespeople have to stay with the tour the entire time, mask on the entire time. The individuals have to be screened. We're only viewing models and vacant apartments. There can't be any interactions with the residents or participating in activities. And potential residents can't participate in meals or things that we would have allowed them initially. And so then next, after a tour would be an admission, the next slide, and then the following slide. So ultimately, we almost did virtually no admissions for the first 30 days, and then we allowed for admissions that did a 14-day quarantine with staff in full PPE. And then our next step, and what we've been doing for the last month, is we allow admissions to quarantine in their homes for 14 days. Now, that's after a screening where we understand what the interactions of the home and the household and the players that are in there, what activities they've been participating in, what activities the resident is imitating. This is a little bit easier to achieve while everybody was on the stay-at-home orders. But in a sense, if somebody was at a facility and was quarantined to a degree, or in their home privately, not leaving the community, then we were allowing them to move into the community. And then admissions from healthcare communities, we require a negative COVID test. And if it was from a healthcare community with an outbreak, it would have been a double negative test, 72 hours before admission. But we actually took the stance of we're refusing any healthcare admissions from an outbreak community at this time. Salon, and then moving on to the next step after Salon. This was probably what we got the most complaints about from residents, is they wanted to let the hairdresser in. I was actually tempted to allow her to come in, but since they were prohibiting that specifically through the CDC and through NCAL, we stopped salon services. So when we resumed salon services in the community and salons were allowed to open, we opened in our communities. And our thought process was, if we didn't open up, residents would leave the community to go get from their hairdresser in the community. So services were resumed, same thing. You can't have services unless you can tolerate a face mask. And the stylist has to wear a face mask. There has to be social distancing, no loitering or gathering before appointments or after appointments. It has to be all done by appointment. And then our staff actually escorts them to the salon. And that was, I mean, I'm sure they've been booked ever since. And then, you know, some notes is right before you start relaxing, and we did this, we developed a Shine program, or a training program for COVID training. So we did another round of training on all of our staff. We did another round of training on all the families and residents, just to, because quite honestly, I was feeling like right as we're getting ready to relax, people are starting to get comfortable. And so we refreshed everybody with that. We also asked people in our communities to commit to be caretakers for COVID positive residents if that were to occur. And so that commitment would prevent people from walking out the job or getting scared. And we took all those individuals that were committed to taking care of those COVID people and did specialty training with them, which everyone has accomplished before July 1st. And so another point I would stress is about communication, and to be very transparent and communicate with your families and your residents, and quite often. And my last tip that I've been telling everybody is, you know, you've been teaching this, or you've been presenting this, or you've been learning this and reading this, but unless you walk around your community and observe what everyone's behavior is, you really don't know what is happening. And so are they donning and doffing their gloves correctly? Are they sanitizing and re-sanitizing? How often are they cleaning those high-touch areas? You have to actually lay your eyes on those individuals to know that it is being done correctly. And my other last recommendation is to survey anyone. We send out a series of surveys to our residents, to our families, to our team members, obviously different surveys, to understand what their perception is of how well we did. And whatever was lacking, we were going to concentrate on that. But if you don't ask the questions, then you don't really know what's happening. And so these are what's happening at the plaza and reflective of what is happening with COVID in our community and our state. It's hard to take the recommendations of what's happening in the mainland because it's such a different situation in certain places, and a lot of times it's very general because it has to cover a range of different situations. And that's it for me. If you have any questions.
Okay, great. I'm going to open this up for questions. I know we have a large audience today, 94 people. And if anybody doesn't have their name typed in yet, please do so. Type your name in the chat box. That's great. All right. Questions?
This is Josh. I just want to make a comment that I don't think you really need Dan or I here because Tricia covered this very thoroughly and I think has a great plan in place.
Thank you.
And there aren't any questions either. So this was great. Everybody, thank you very much. I had a great time. Josh, nice seeing you.
Yeah, Dan, good to see you too.
Okay, well, I have a question.
Besides, we're from that horrible mainland anyway, so we don't count.
Well, I have a question. So what happens?
Isn't that what you said, Tricia?
I just, I actually have a lot of respect. My understanding is that you actually had to deal with the virus, and we feel very grateful that we've, I can't take credit for it, but we've lucked out and not had to have a large surge on our hospitals and our healthcare system and even our communities. I think a long-term care in Hawaii has done a really great job of keeping this virus out. But we need people like you because you've experienced it. And I've learned so much from all the different webinars and hearing the war stories. So just happy to be on the late end and not on the early end.
Oh, right.
And
go ahead, Josh.
One thing I would just really emphasize, and it was, I think, in one of your first slides, Tricia, is the idea that as we reopen, we should simply assume that every person walking through the door could be bringing the virus with them. you know, we'd love to all think we could put our communities in a bubble and they're never going to be exposed, but that's an unrealistic expectation. And we've definitely seen in the last couple weeks, really across the country. I mean, we're all following it, of course. We're seeing the surge in cases in many, many states. And with that, we've seen a pretty significant surge in cases in the communities that we work with. And so it's, you know, it's not that we're giving up, of course, on keeping the virus out. We do all the things you described with screening and PPE and social distancing to try and keep it out. But it has, I feel like there's been a little bit of a shift where we're focusing a little more on responding to the virus. So when it shows up, not so much if it shows up, but when it shows up, what are we going to do? You know, we're going to shut down dining. We're going to shut down activities. We're going to isolate for 14 days. You know, we're going to respond appropriately. We're going to test people. That's really become a big shift for us. And I'd say really the last 2 weeks.
Yeah, so needing to set that expectation early on with all the residents there, like, hey, looks, you know, opening up, you got a little freedom. But, you know, the minute we have a staff test positive or a resident test positive, you know, we shut down again and we have all the contact tracing and everything going on. Yeah, so that was going to be my question. Like, what would you do if one of your staff, you know, tested positive, you know, in terms of that?
And you know, the staff testing positive is one of the most tricky situations we deal with. You know, residents testing positive, it's a no-brainer. They're in the community. We need to shut down. Staff testing positive, we're trying to look at it on a case by case. So it's all the things you would expect. You know, when were they last in the community? When did they test positive? Seeing if we can piece together a timeline to try and understand if they may have been positive while in the community. You know, the simplest example, and it's a no-brainer that I had someone run across me a couple of days ago, is they have an employee in California. There's now a mandate to test the entire community if anyone tests positive, and there's a lot of states that have gone in that direction. And so I had someone email me. She said, hey, my marketing director is on maternity leave, and I just found out she tested positive. Do I need to test the entire community? And I said, well, when was your marketing director last in the community? And it was like 2.5 months ago. So I said, no, you don't need to test the entire community. So they're not all that simple, but I do think with employees, it's worth kind of going through the exercise to try and figure out, you know, could they have been positive while in the community? And if it's a clear-cut case that they couldn't have been, you know, I think that helps to dictate your response.
Great.
And you know, I think also, go ahead, I'm sorry.
No, I was going to say I have a question in the chat box, but you can respond quick if you want.
Well, I was just going to say, I think that I like to say positive things when we're talking about the COVID. And I've been saying this fairly frequently, is that I think there's a big difference now between, you know, late March, early April, when it started and you had a one positive case and everybody freaked out and the thing spread like wildfire and you had all these asymptomatic cases and lots of deaths. I think we're so better prepared now that, and I think that's a terrific thing. You know, we know resources, we know what to do. You may or may not be able to keep it out of your facility, but I just think because we're so better prepared, I think we're actually going to save lives. Now, some of the stuff that we're talking about, you know, testing is an issue, and Josh alluded to that. And it's more of an issue, you know, if you get cases, right? Because what a lot of times the government does, and I'm not being critical against government, is, you know, they try to fit this into a one size fits all, and it really doesn't. You know, like one of the lessons that the government, I don't know if that we don't do is, like, once somebody's positive, you don't have to test them anymore. So what we've found is, like, we've had cases who've been positive, tested negative twice, went to the hospital for some other non-COVID suspicious thing, and tested positive there. So what does that mean? Now the facility has to go back to square one and close down again. It's tough, you know, and who do you test? The other issue is with, you know, do you trust visitors? One issue we've been having, which you actually might have there, is like we have a lot of the chat boxes and trying to get people outside. Well, what if somebody comes, and I don't know if, Trish, I don't know if you want to comment on this, or Josh, somebody calls up and the daughter's coming from Texas or Arizona to visit mom,
Yeah.
right? What do?
We made the decision that, so in Hawaii, what is happening is on August 1st, they're going to lift the mandatory quarantine for travelers coming into the state. And we anticipate as a state that, it's going to start rising. Now, they're lifting the 14-day quarantine, but they're also requiring a COVID test 72 hours before you travel. That being said, we don't know how that's going to work. And so we are not lifting the travel ban on our screening as of 8/1. We're lifting it for inter-island travel. We're not lifting it for international or domestic travel. And, quite frankly, we just want to take a wait and see approach of what happens in the community before we make a decision to allow people to visit in that have travel. And that's hard. We have a lot of families from the mainland.
Yeah.
And,
I think it's safe because you don't want to throw away. We've done all this effort for 3 or 4 months, and to throw it all away by taking, too much risk. So I think that's a good idea. Go ahead, Josh.
Well, and I think the visitors are an interesting challenge because, obviously we don't want to introduce unnecessary exposure. But on the flip side, I mean, the one thing I think we sometimes don't want to say out loud is the real risk of exposure for our residents is our staff.
Yeah.
They're the ones that are coming and going.
Absolutely.
They have to. And, we talk about the 6-foot social distancing. That's really not possible for a caregiver who's, got to go in and help a resident with medications or take a shower or transfer out of bed or whatever it might be. So maybe I'm crazy, but the visitors don't make me nearly as nervous as, for example, communal dining, where you've got residents. I mean, we do the 6 foot and we do the masks and we do all those things, but nevertheless, you've got residents, with some interaction with one another. The visitors, I feel like we can control, and again, Tricia outlined it, I think, perfectly how you would do that with limiting the number of visitors and requiring they wear a mask and they have to perform hand hygiene and all the things she talked about. I feel like we can control visitors pretty effectively, and they really don't make me nearly as nervous as some of the other things related to reopening. Most of the cases we're seeing with the surge, in a lot of states are really being connected back to employees who've been exposed somewhere outside of work.
Absolutely.
I want to just, we have a question from Guam. So, Margaret from Guam, let's see, says here.
It's not a good webinar without a question from Guam, in my experience.
Margaret, are you on? Do you want to ask your question live?
Oh, hi. Sorry, I just had someone step in the office. But yeah, so we, we have a nursing assistant program in our nursing school. We also have a RN program, but Ida knows very well part of our geriatric grant is that we have to produce nursing assistants. And so, of course, since March, that's been on hold, and we've just extended the state of emergency another month. And so the employers are begging us to start our CNA training again. And right now, all our long-term care facilities, I mean, it's not very many. We only have one that's Medicare certified. There's zero, they have no COVID, and they've been on lockdown since March. So of course, I don't want to be the one to bring in COVID with students. And so I've just been very, very conservative, and just was wondering, for your assisted living facility, are you having students, or, what your thoughts are? I don't want to be too conservative, but we, on Guam, we can't fly. Well, you can't either in Hawaii. We can't fly in caregivers. So,
I have
so it's a problem, but any advice would be appreciated.
I have 2 comments. One is we were contacted to run clinicals for nurses and nurse aid programs. And I hate to say this, but we refused. I just didn't want to take a chance and unnecessarily. Now, that being said, we never suspended our recruiting efforts. So we, since day one, have been recruiting nurse aides and nurses, charge nurses at our communities because we were fearful that we would have to quarantine people. People would get sick. And so we were so fearful that we were training them. Now, we trained them off-site. We trained them in this huge room that's socially distanced. And they go through the program, and then they are obviously released to the properties. And we used to average about 30 vacancies across all of our platforms. And now we have about 12 vacancies across all of our platforms. So this was a workforce improvement, if there was one good thing that came out of COVID. So I would have liked to help out this school and increase those nurse aides, but didn't take the risk. But as for ourselves, we wanted to continue to recruit and place people in the properties.
Hey, Josh, have you seen at the places you work the issue of students and aides?
You know, honestly, we don't have a lot of student programs in the communities that we work with. The only one that comes to mind was actually a community near San Francisco that was a memory care community, had a pretty significant COVID outbreak. You know, probably about 70% of the residents eventually were infected, a number of deaths. They're just now coming out of this outbreak. They've gone through 2 rounds now of negative testing. They did have students in the community and continue to have students in the community throughout that. In fact, the students ended up being a key part of staffing the community. They ran into pretty serious staffing challenges related partly to people refusing to work and partly to staff who were infected as well. And this was a building that, I mean, their outbreak started in early April. So they were a very, you know, they were one of the early communities to be dealing with it. So, you know, I don't know, obviously, how much the student issue played into anything in the community. I kind of go back to what I said earlier, that so long as we have staff who come and go from our communities, which we have to have, I think other people coming and going from the community can be effectively managed in the same way that we're managing our staff. So it's, you know, and I think particularly listening to Margaret's situation where they have I mean, we feel like we have a hard time finding staff in the middle of Los Angeles and San Francisco and you know, Dallas and Houston. I would imagine on Guam, you have an even significantly more limited pool of potential staff. So it would seem to me her program is a key part of providing the staff that we need to serve residents in these whether it's AL or skilled communities. So it would seem to me it makes sense to find a way to keep that program going. Obviously, you'd want to make sure those students have very strong infection control training before they're allowed anywhere near residents or other staff. But it would seem to me it would make sense to find a way to get that program back on track.
Yeah, and in some sense, I've expressed this before. Is can you I don't know, require a higher level of integrity in the sense, like, if you're going to be a student here, you cannot be going out partying on weekends and all that sort of stuff. You know, you really must try to socially distance us at a very high level if you complete this program. I don't know if, you can't require these things, but in some sense, students, you sort of can. But you depend on their honesty. So I have a couple of comments here, which actually was addressed. Tricia, have you folks develop a testing plan if one of your facilities potentially developed a case? And a comment from Al Yazao that D. Robinson developed a good flow sheet on how they would do so at One Kalakaua if one of their staff tested positive. I think this just really underlines the fact that, yeah, everybody needs to have a plan, because it's not if, it's not a matter of if, it's a matter of when.
Yeah, so if we get a positive case, whether it's a staff member or a resident, we do plan on testing all of the staff and all of the residents. And then we would probably set up some interval training, you know, a week later, until we've got double negatives. But, you know, there's two comments about testing that worries me. A is the accuracy rate or the prevalence of false negatives. And I also, what I learned recently, I had somebody go to CVS because CVS has been identified as one of the providers of testing for the travel program. And you had to administer the test yourself. So it was a nasal swab that you had to administer to yourself in order to get the test. And my thought was, well, it's going to be negative because I'm pretty sure you can't self-swab accurately. And that might be the prevalence for the inaccuracies. But I don't have a solution or a lab of something better. I guess that's the best that we can do.
You know, I think testing is such a tricky piece of all of this, and it's become such a big focus for states that are reopening. Personally, I feel like we're focusing too much on testing. Not that it's not important, of course, but I feel like we're focusing so much on testing when we should be focusing on all the things Tricia talked about with social distancing and masks and just good infection control practices. But the self-swabbing, I do just want to comment on, because we've seen that in Florida, they're now mandating that staff of assisted living communities must be tested every 2 weeks, starting, I believe it starts next week. And the way they're going to do it, the state is sending test kits to the communities for the staff to self-swab. And I think that's a big part of that is the CDC's shift, probably a month ago now, a while back now, to the shallow nasal swab, the anterior nares swab, instead of the nasopharyngeal. I feel like the majority of testing has shifted to that sampling method. And one of the reasons, from what I understand, the CDC did that was to allow for self-swabbing. There's also, I believe it's Abbott, or maybe it's Abbott. These labs are swimming in my head now, but there's a lab that provides self-swabbing kits that you can order, and they'll send to, I suppose, anywhere, your home or your community or whatever, for people to self-swab. But I think Tricia's right. There's definite issues with the testing and false negatives. And from what I've understood and looking at the research, a big part of the false negatives is with bad sampling.
Yeah, I think that's what I've been saying too, Josh. I think the majority of people around here are going to the anterior nares nostril swabs just because it's so better tolerated. But we're in a different position on the mainland than they're in Hawaii. I mean, any state I think that has had outbreaks, I think it seems to me the vast majority are going to universal testing. It's like, you know, at least 1 point prevalence to see what you've got. So, I mean, that's where places where you have COVID in the community. So it may come to that. We had, you know, there was a point here where you could get a test from CVS and we couldn't get them in our personal care facilities. And one of the issues that I'd heard from CVS was that there was a long turnaround time, that you couldn't get quick results back. Now, what's happening now, and I'm sure you read this in the news, is that there's an overwhelming desire for testing. So what's happening now is it's harder and harder to find, and the turnaround time is getting longer and longer. In my facility, we're doing weekly. I got swabbed on Tuesday and got the results back Sunday night. That's 5 days. or you got an accountant at home. That's you know, that's not so great. But you'll see. I mean, there's other intricacies to this, which Hawaii's really lucky that you haven't had to get to yet. One of the things that we haven't talked about, and I think it's good that you haven't had cases yet, is where does antibody testing fit in all this? You know, because I think it's going to have a place, but we're just not sure of that yet.
Yeah, I think there's real significant concerns with the dramatic increase in testing and what that means for turnaround time. We've been fortunate to work with a few labs that have been turning tests around pretty consistently within 48 hours. They were already processing about 5,000 tests a day. And that was before, I mean, so many states have gone to some form of mandatory testing. And I think the real serious, or a real concern that those labs will be overwhelmed. I mean, like, to your point, Dan, 5-day turnaround on your results, you get to the point where the results come in so late, are they even useful? You're halfway through your 14-day exposure period when you get your results.
Well, I feel great. I don't know if I said that. I feel good.
You look great, Dan.
I do. I know it's the hair.
So Dr. Yazawa mentions that there is an assisted living facility in Kapolei using antibody testing weekly as a form of surveillance. That's odd. Yeah,
No,
it's not my understanding that it's useful for surveillance, but
yeah, no, don't do that.
Yeah, that not make sure. So Trish, I was wondering, so if your facility, somebody in your facility tests positive, if it's a staff member, who does the testing of your entire facility? Is it your staff, or you call on Department of Health, or?
Well, I would hope that when we reported it, Department of Health would get involved, and then that would happen. The backup plan is we've been talking to labs, and they have offered to be able to go out and do testing. So and obviously if we're testing all the residents and all the employees, they would come out and conduct that testing. I just want to share that it seems very apparent that DOH in Hawaii is not in favor of doing widespread asymptomatic testing on long-term care. And I'm not sure if that's a financial thing or not, but I'm not really sure if that's going to end up being mandated in the state.
Yeah, I don't think we have anybody from DocD on this call. Unfortunately, we'll have to pull Katie and Sarah into this conversation next week, next session, I think. But yeah, I think it has to do mostly with whether they're following they have to basically follow CMS guidelines, but other people can certainly test more if they want to, and those might not be covered. And that's kind of the issue. I think it's a coverage.
And I think so too, is if you have a low incidence in the community, right, you have a very low incidence, then I don't think it makes sense to do that, because you're not going to turn up asymptomatic cases, right?
Yeah, so they're of the mindset of they're going to go in and basically interview everybody and then sort of figure out the strategy from there, and work very closely with facilities. So far, we've had a couple of sparks set out in a couple of nursing homes as well as care homes, and fortunately, it looks like been able to put out those fires for the most part. I am kind of wondering on the mainland, what is your experience in terms of, okay, if you opened up, people are starting to leave their facilities and going out. Are you able to rein it in again once you've opened up? Is that possible?
It's interesting. We've had, I haven't seen any significant, we work with about 350 assisted living communities around the country, and I haven't seen a significant surge in cases related to community. The community itself has opened up, whether that's visitors or dining or whatever. Where I feel like we're seeing the pattern of increased cases are just in those areas where the state or counties have opened up the general public, which is, kind of a no-brainer, right? You know, as the general public opens up, people are out and about, you're going to see more cases of COVID. And again, there's those connections to our staff who come into the community and bring it with them. It's also, and I think to, you know, Trish's comment a second ago about testing and you know, what your health department's planning, it's I suppose kind of a controversial part of all of this, but I think there's a real, to me, it'll be interesting to look back on this in a couple years when hopefully COVID is in our rear view mirror, and we can take a look at how we've approached testing and if it was the right path. Because I know in our communities, we're seeing about 70 to 75% of cases of positive COVID cases are asymptomatic and remain asymptomatic. And that includes both staff and residents. Now, of course, we have had residents who've been seriously ill. We have had residents who have died. We have had staff who have died. So I'm not trying to suggest COVID isn't serious, but and it's hard to advocate for sticking your head in the sand, right? Like, let's just put the blinders on and not test anyone and cross our fingers and hope we get through it. But I do wonder a little bit in these states where we are doing just an incredible amount of testing. I mean, in New York, we're testing staff twice a week. And I'll be interested to look back and see if that was really the right choice. Did that actually help contain the spread? Or did it simply identify huge numbers of asymptomatic positives that otherwise would have gone unnoticed?
Okay, so we had a comment from 15 Craig's side. With the increase of COVID in the mainland, how has that affected your PPE supply? That's ordering and use. Having adequate PPE supply is a factor we continue to look at prior to relaxing restrictions.
Well, let me comment briefly before Josh. Is that's an issue? I think it varies on area. Some areas are doing okay, some aren't. But two things that you worry about. One is, well, both are around the same thing. One is that if you're afraid for a surge or a second wave later on, what some of the assisted living communities I'm looking at are trying to stockpile things now. They're trying to order PPE now, and even when you order it now, you may not get it for months and months and months. That's one thing. The other thing that we're particularly worried about, and it's good for your relationships with the Department of Health, is I think there's going to be PPE shortages when businesses open and schools go back in, right? Because we just have to make sure. I'm glad I have the opportunity to say this. We have to stick up for our assisted living residents. They're much higher risk. Although the virus changes, they say now it's getting more younger people. I know that. But my concern is that PPE may become limited when there's more of a pull from other places. So Josh, what's your take?
No, I agree with all that. I mean, right now we're not having issues with access to PPE. We are still doing extended use. I was just thinking about that today, actually, as I was answering some questions. Is we're still using PPE in a way that a few months ago was unheard of. Reusing.
You would have never dreamed of.
Yeah,
right.
Yeah. Wearing the same mask for 3-4 days in a row. Using the same gown. Over and over again, and we're doing some pretty wild stuff still. But with that realization that we're doing extended use, we're not having major PPE access issues. But I agree with Dan. I think what we're all trying to do right now is stock up, knowing that we may need more of it soon.
So our assisted livings here stocking up now before the storm?
Just so Plaza, all of our communities try to get and grab as much PPE as possible, and they all have a supply that if something happens, they'll be able to. And then we saw that HHEM was gonna have a problem with keeping for emergency purposes. Just the hospital alone was eating up PPE. So as a corporate office, we started obtaining large supplies that we were keeping. And if we have a COVID outbreak or even just a case at a community, we would be able to stock them. I will tell, so we've got, tens of thousands of surgical masks and gowns and those type of things that were difficult to obtain. And just today, we finally were able to get an order of N95 masks. Now, I'll wait to receive them before I really get happy. But it is, I think you're right. I think there's a little pocket of time where things have loosened up and you can get some supplies, and this problem isn't going to go away, and you've got to get as much as you can. And I think that we're lucky that all of our facilities are 5 miles within each other, and we are able to transport supplies easily. And it's easier than stocking 6 or 7 facilities.
Yeah.
So,
Dr. Izawa, I have a question. So could you give us an idea of what the state of HHEM is in regards to PPE supply? Is this really true that it's not quite enough and everybody has to fend for their own?
Well, the national stockpile stuff is coming through HAIMA to HHEM. We have a ESF7, which is the supply section for HAIMA. They have been ordering supplies of PPE on an ongoing basis. I think early in the pandemic, we were competing with other states, much larger states that had larger budgets, and it was a bidding process, and it was difficult for a small state like Hawaii to get the PPE that we needed. I think that now, though, those supply lines have been opening up, and PPE is available through HHEM. There is a tiered system. So obviously the first tier are folks that are already dealing actively with COVID positive cases. And then, of course, various congregate settings, first responders, things like this. So hard question to answer. As you know, the legislature is dedicating $100 million towards purchasing more PPE. That's being worked together with several state agencies as well. So hopefully I think what they're trying to do, that just-in-time kind of PPE usage. So if when you get COVID, you won't be lacking in PPE, because suddenly you'll have this surge of PPE that will be provided to you. But until you do, that's certainly an issue.
Okay. All right. Well, that's good to know. Thank you. Other questions or comments?
Ada, I was just going to say, just one thing is, it's interesting, Josh says, when we look back at this, what are we going to look back at? So it'll be interesting. Testing is one thing. One thing that I think is evolving now at other places around the country, which, whether you have COVID or not, is the whole idea of, the damage that's being done to people after being cooped up for 3 or 4 months. I think it's a little extreme, but they're saying, well, we've kept our residents in prison. I wouldn't say that necessarily, but it's the subtleties of this is, if you're really going to be an advocate for patient-centered care, right, then how is there a way where you can give residents a more informed choice? This applies a lot to residential living, but also applies, to the more mobile people in residents of assisted living. Can you take somebody? If they're aware of the risk, do they put other people in danger? What's the value of increasing their socialization? So I think that's a topic that is coming to the fore more now, which I think is interesting.
I just will share with you, that was a very big concern when we were talking about relaxing and struggling the safety and the emotional health of our residents. And so we did a sampling, a GDS scale or assessment on all of our communities. So we had a baseline from their last service plan. We did a sampling of everybody in the midst of COVID, and we will do a sampling, after COVID and after we relax. And I'll tell you, In the initial results, because those are still coming in the initial results, a third of our residents increased their GDS score by 1 to 3 points, which wasn't super significant, but 33% of us, there was a difference. And there was a very small, so 2 individuals that had a significant increase, and obviously we addressed it. But I think that a third of your community, and now what if we had stayed buttoned up for 6 more months? Maybe it wouldn't have been 1 or 2 points, maybe it'd even been more. But I think it was worth looking at and analyzing it and having a realization that this isolation or this modified isolation does have an effect on people.
Yep. Okay, thank you. We will end on that note and keep us inspired to be creative, hopefully, in finding ways to continue engagement, because I'm sure that's kind of the next step is engagement. Okay, so in conclusion, in order to get your CMEs, go to our webpage, complete our online evaluation form. That was in the chat box as well a little bit earlier. And just remind you that the next session is not next week, it's the following week, the 15th, and we're going to talk about COVID facilities and surge planning in Hawaii, lots of opportunity for Q&A. And then in August, we will talk about hospice care in the time of COVID. So thank you very much. And remember in your evaluations, write down topics that you would like to see, and we will try to squeeze all those in. Thank you, everybody. Thanks for joining us. Thank you, Tricia. Thank you, Dan. Thank you, Josh. See you again.
Thanks for having us. Take care, everybody. Bye-bye.
Bye-bye.